So as I mentioned, we are really pleased to have Dr. Fatima Rodriguez here with us. She's the assistant professor in the Division of Cardiovascular Medicine at Stanford University, and she's a non-invasive and preventive cardiologist. Dr. Rodriguez earned her medical degree from Harvard Medical School and her MPH from the Harvard School of Public Health. Zuckerman Fellow at Harvard Kennedy School's Center for Public Leadership. She then completed her internal medicine residency at Brigham and Women's Hospital. She arrived at Stanford University in 2014 when she completed a cardiovascular medicine fellowship and served as chief fellow. She currently serves as a section lead of Preventive Cardiology in the Division of Cardiovascular Medicine. Dr. Rodriguez's research interests include a range of issues relating to racial and ethnic disparities in guideline adherence, cardiovascular disease prevention, Hispanic cardiovascular health, advancing scientific workforce diversity, and leveraging technology to improve the care of diverse patients. She has authored more than 160 peer-reviewed publications on these topics, and she has received multiple awards from either Stanford or external awards. So we are really honored to have you here with us, Dr. Rodriguez. Please take it on.
Thank you so much, Susan, for the introduction. I'm going to go ahead and share my slides, and I'm sure I'll share the wrong screen, so you can tell me to do the swap. Okay.
That's perfect. Thank you.
1 second. Let's go to slideshow. Are you guys seeing the correct slides?
No, you need to swap.
Okay. Every time. Okay.
Perfect.
Correct slides. Okay, perfect. So that's step one. Well, thank you so much for everyone for being here and showing interest in this topic, which is dear and near to my heart. And there's still people trying to come in. So Susan, will you let them in? I've been admitting them to the chat. Yes, and it's great to see so many friends and colleagues from different parts of my Stanford life, including my nursing colleagues and my mentors, collaborators, and trainees. So thank you all for, hopefully everybody can get something practical out of this talk. So the topic today is health equity and cardiovascular disease prevention, opportunities for research and practice. And again, keeping in mind that many of you are either practicing clinicians or researchers in the space of any topic, really, you can bring a health equity lens to that. These are my disclosures, which are not relevant for this presentation. So I've organized this talk around 3 learning objectives. The first is understanding how social determinants of health impact cardiovascular disease prevention. And we'll just spend a little bit of time defining terms and understanding what social determinants are. We're going to specifically call out structural racism as a barrier to achieving health equity and identifying structural racism and structural barriers to achieving health equity. And we're going to end with a positive and very practical note of things that we can do in our everyday practice as research and clinicians to promote health equity and cardiovascular disease. I'd like to center this presentation around a patient case, and this is a patient that I took care of for many years when I was a medical resident at the Brigham and Women's Hospital in Boston. She was a 72-year-old Puerto Rican woman with very poorly controlled diabetes, hypertension, heart failure with preserved ejection fraction, and advanced coronary artery disease. She was frequently hospitalized and readmitted. She spoke no English, had a very low health literacy, and in fact, could not read or write in Spanish either. And she lived in a predominantly Hispanic, low-income neighborhood right across the street from the Brigham. So she had access to this really top-notch healthcare system, but again, lived in unfavorable social conditions. She saw many specialists, particularly during her hospitalizations, and had a total of 28 medications that were prescribed. She was extremely distrustful of the healthcare system and would come to her medical appointments with a bag of all of her medications and saying, which ones do you think I should take? And again, I was a medical resident, but she felt more comfortable sharing this with me than with many of her other clinicians. So let's just keep her case in mind as we go through this presentation. So cardiology, unfortunately, reigns supreme in terms of the leading cause of death worldwide. Even after COVID, heart disease was still the #1 cause of death in 2020, followed by cancer and followed by COVID-19. But one of the reasons that cardiovascular disease and cardiovascular prevention in particular are so fascinating is that we can prevent 80% of cardiovascular events through lifestyle and aggressive control of cardiovascular risk factors. And although we've seen significant gains in cardiovascular disease mortality over the decades, as we see here, there has been a recent uptick in cardiovascular mortality. And this is thought to be due to an increase in cardiovascular disease risk factors and poor risk factor control, particularly among our most vulnerable and largest growing communities. So this is recent data from the American Heart Association, again, that's showing that compared to 2008 and 2018, there are fewer deaths from cardiovascular disease. And that's good. But again, we can see that these gains have not been done proportionally for all populations. In 2018, Black adults are still 32% more likely to die from cardiovascular disease as compared to non-Hispanic white individuals. Even more striking statistics when we look at things like stroke, with Black adults are 45% more likely to die from stroke, as shown here. And when we think about cardiovascular disease prevention, it's really a continuum. As a cardiologist, I spend a lot of time treating patients that already have disease. But ideally, we would focus on primordial prevention. So the term primordial prevention means the prevention of risk factors. And I have to emphasize that this cannot start early enough. So this begins in childhood, in fact, even in utero. Primary prevention is preventing disease before it occurs, and this is really through the control and identification of risk factors that we know cause heart disease, diabetes, hypertension, obesity. Something that we call prevention 1.5, individuals that don't yet have visible cardiovascular disease, but may have things like coronary artery calcification. So prevention 1.5. Again, what I spend a lot of my time doing clinically is focusing on secondary prevention and high-risk secondary prevention for patients that have established disease. But I would argue that's probably too late. And the biggest bang for your buck is really to focus upstream and focus on primordial prevention and primary prevention. We also know that disparities in cardiovascular disease are prominent across the life course, and they begin early in life in utero and actually persist throughout the life course. So we know that all of these factors are cumulative. So we talk about things like pack years for exposure to tobacco. There's also pack years for all sorts of other things, including chronic stress, including adverse environmental conditions, even cardiovascular risk factors like high cholesterol. And when we do our research studies, we need to consider a life course approach. And again, in a lot of epidemiological studies, we focus on a baseline risk factors and then follow it over time. But I would encourage all of us as researchers is to really think about the change in these risk factors and getting multiple exposures. So here's an example from the CARDIA study. So the CARDIA study, in case you're not familiar with it, is a large cohort study called the Coronary Artery Risk Development in Young Adults. And it really shows the importance of examining the development of risk factors early. So they have a lot of follow-up, and we can see the BMI trajectories of everyone over time. Not surprisingly, it increases for everybody. But again, you can see that the largest increase here is actually for Black women. You start higher, but that delta actually gets higher as you go through time. So this work really emphasizes that you really can't start soon enough in the life course to target interventions to reduce cardiovascular risk factors. So why do we talk about the social determinants of health? There is a clear social gradient in health. So whatever the socioeconomic metric is, whether that's income, education, social position, occupation, there is basically a linear association with overall health. And you can really change whatever overall health, cardiovascular health, cancer, whatever chronic condition. And that's been replicated in multiple studies. And that's really the basis for us studying the social determinants of health. So let's define what the social determinants of health are. So social determinants of health are the conditions in the environment where people are born, they live, they learn, they work, they play, they worship, and it affects a wide range of healthcare functioning outcomes and risks. things like the neighborhood and the built environment, economic stability, education. And education is probably one of the best things to study because that tends to stay fairly stable throughout the life course. Social, cultural, and community context. And a very small part of this is healthcare. And I know that's something that we spend a lot of our time thinking of improving access and healthcare quality. But in fact, almost all the other factors are much more important and occur upstream of the need for use of healthcare. This is a famous study called the Whitehall study of 18,000 British civil servants, and it shows the association between social class and mortality. So in England, the administrative grade is considered the highest level, as shown here. And then as you go down in social class, you can see the cumulative mortality increases. So even more interesting, if you look at the next panel, this figure shows us the extent of the relative risk of dying from heart disease is explained by traditional risk factors, but that also varies by social class. So as you move down to the lower social classes, more of the risk is unexplained by traditional cardiovascular risk factors as you move down by social class. And these authors poignantly conclude, a man's employment status is a stronger predictor of his risk of dying from coronary heart disease than any of the more familiar cardiovascular risk factors. Another thing that we have to think about when we talk to our patients and our colleagues and we're conducting our studies is where you live. So this is a really striking aerial view of Santa Fe, Mexico City. And you can see, again, these are the same picture, aerial view, the different opportunities that people may have to live and enjoy a healthy lifestyle, depending on where you live. And there are many of examples of this in the United States as well. But again, look at the differential access to green space, to safety, and the things that the built environment really can afford in terms of adhering with medical health recommendations. A more contemporary example close to us is life expectancy in the San Francisco area. So just for reference, I know many of you know, but San Francisco is small, it's 7 miles long and 7 miles wide. And you can see that life expectancies across the different zip codes can vary as much as 13 years. This is in one of the wealthiest cities in the United States. And if you trace back to historical practices, these differences in life expectancy can be traced to historical redlining practices, which we'll talk about. Here's a map from the CDC showing the percent of the population living in poverty. And then you can see the map here to the right showing heart disease deaths, again, in adults. And basically, big picture, you can superimpose these two maps. As you increase county level of those living in poverty, you have more heart disease deaths. So very much intertwined. For those of us that are clinicians, and I discuss in the patient case, we think a lot about medication adherence, especially for cardiovascular disease. We have a lot of medications that work really well if people take them, and many of them are cheap. But we can understand the intersection between social determinants of health and medication adherence. If you are unemployed, if you lack social support, even what we may consider a minor cost or inconvenience to taking a medication can have dramatic effects on the medication adherence. Low education and the risk of misinformation, particularly at lower health literacy levels. And then even things like the distance from the treatment center. I have patients who come to see me in clinic who they may run out of their prescription. And again, it's something important like a blood thinner, and they won't think to reach out to say, hey, can you refill this medication? And they wait for an appointment. So again, you can see a lot of areas where communication gaps can play into that. And all of these are intrinsically tied to their social determinants of health. So in this clever study that was published in Circulation, Quality and Outcomes, we can see that lower medication adherence, even in a group of a Medicaid population, this is already a lower income population. Those that had higher social vulnerability, and this is group 4, you can see again a graded relationship with worse medication adherence to antihypertensives as your social adversity group increased. And again, this is all individuals were on Medicaid, so this is really taking away even the economic factor, but things like education, employment, food, housing, and security, all those factors create a social adversity, and we really need to be mindful of that in our patients. For those of you interested or around mechanisms, how do you link social determinants of health to the biology of cardiovascular adverse outcomes? There's a wonderful review paper published in Circulation Research that can show this. So chronic stress can really create a pathway to chronic inflammation, and this is mediated through biological mechanisms and then produces the risk for developing cardiovascular risk factors and the progression of those risk factors and ultimately cardiovascular events. And there's actually a center at UCSF, we call the Nurture Center, led by Michelle Albert, that really focuses on studying the biology of adversity in resulting in health inequities. And this is really important because there is a biological pathway, again, that these factors can lead to cardiovascular disease risk factors. And you can see here that this is not race as a risk factor, right? This is race is associated with these factors, and we'll talk about that. So now we're going to shift gears to learning objective number 2. And before I do that, are there any burning questions? We're going to have plenty of time for Q&A, but if there's any burning questions, you can take those. You okay? Susan in the chat, nothing burning?
Nothing in the chat.
Okay, sounds good. We'll have plenty of time at the end.
Just comments and compliments that this is great data.
Thank you. So now we're going to move to learning objective number 2, which is calling out structural racism specifically as a barrier to achieving health equity. So you may be asked this, and this happens to a lot of us who do research in this space, why consider race at all? You know, you've said race is not biological. Can we just focus on social determinants? Is that enough? And to briefly answer this, I'll say that race is not a useful genetic category, but it is a profoundly useful social category. At every level of income education, there's always an effect of race. And even wealthy Black Americans are less healthy than white individuals with the same socioeconomic status. And we can talk a little bit more about that in the QA. But let's look at some data. So this is work that was led by a wonderful medical student in my group, Ongeka Zuma, and Justin Parizo, who was a fellow with us, looking at different county level factors associated with cardiovascular mortality by race, ethnicity. What you can see here is that we try to identify factors at the county level that were associated with a higher proportion of cardiovascular mortality. And what we found is that for Black and Hispanic individuals, socioeconomic and demographic factors explain much more of the variation in cardiovascular deaths, whereas for non-Hispanic white individuals, cardiovascular disease risk factors, those things like hypertension, diabetes, smoking, explain much more of that risk. So really important to understand that different factors may contribute to cardiovascular disease mortality differently in different populations. It's also striking, as you can see in this map, again, pointing out to segregation, that the Black individuals tend to live in certain parts of the United States, Hispanic individuals in other parts of the United States, and geography really matters. The counties where these individuals live matter. This is a map of California showing disparities geographically, even in highly affluent areas. So here we see data from our county, Santa Clara County, San Mateo County, again, very highly affluent counties, as we know. Still in these counties, in Santa Clara County, Latinos are 11% times more likely to have diabetes, 18% in San Mateo. In the North Bay, another extremely wealthy county, Asians have 18% higher diabetes prevalence. So again, even within these small units of counties, there are still racial ethnic disparities. This is a study that was just published in the Journal of the American Heart Association, again, showing that within the same educational levels, there remain racial ethnic disparities in outcomes. So this has recently actually been upgraded to Life's Essential 8 from the American Heart Association, which focuses on ideal cardiovascular health. And these include not smoking, healthy diet, physical activity, weight, blood pressure, cholesterol, and ideal glucose levels. The Essential 8 has now added sleep to this. So these are basically the 8 behaviors that we can track with our patients to ensure not just being free from cardiovascular disease, but obtaining ideal cardiovascular health. And what these authors found is, again, that there's a gradient, like we discussed. The higher your education, the higher the odds of having ideal cardiovascular health. But you can see that the magnitude of that benefit is actually much lower for Black, Hispanic, and Asian individuals in this cohort. So what is race? Let's spend a few minutes talking about definitions. So this is a wonderful definition by Dorothy Roberts, who is a justice advocate and a professor at UPenn School of Law. Race is not a biological category that naturally produces these health disparities because of a genetic difference. Race is a social category that has staggering biological consequences, but because of the impact of social inequality on people's health. Really powerful and accurate definition. Racism as the cause of health disparities. So racism is a system of structuring opportunity and assigning value based on our social interpretation of race. And Cameron Jones has described 3 levels of racism, which are intrinsically interrelated and which all have unique impacts on health. And these are all been rooted on historical practices such as redlining that we've heard about. And these have effects on opportunities and wealth. We've talked a lot, there's been a lot of focus on structural racism, especially with the COVID-19 pandemic, but there are other types of racism like internalized and personally mediated racism, which we won't discuss today, but are also important. Institutional or structural racism is defined as the differential access to the goods, services, and opportunities of society by race. These are normative and sometimes legalized. Again, they're structural, they're codified into our policies, governments, and institutions, to our legal system, and to our healthcare system. So how do they manifest? They manifest in things like having some people have better quality education, sound, safe housing, access to appropriate medical facilities, clean and safe environments, and gainful employment. And I'll give one example related to site of care here. So during the COVID-19 pandemic, we found that site of care really was one of the primary predictors of mortality for individuals hospitalized with COVID. And for all of you who are healthcare practitioners, that should not be surprising, because we know that staffing issues, overwhelming access to the new therapies as they became available may have been limited. Unfortunately, we did not have that problem at Stanford as much as other sites. There's also differential access to power. So there's resources such as wealth and organizational infrastructure, differential access to information. I'll give you an example of that. Voting rights, representation in media, who's controlling our media and in misinformation. I was really proud to be part of this statement from the American Heart Association that explicitly called out structural racism as a major cause of health disparities and premature deaths. And again, this was a shift from the American Heart Association that had basically done papers on each thing like education, housing, but really the umbrella as a cause of disparities is structural racism as a barrier. And this paper also outlines against mechanistically, how do we link anti-Black structural racism to poor health? And again, we need to understand the history to understand how we got to where we are. I'm sorry to bring in COVID-19. I know we're all very tired of COVID, but just again, a very, very compelling example of how structural inequities impact health directly. And again, all these inequities existed way before COVID, but of course, it's just brought them to the forefront. This is data from the American Heart Association. We created a COVID-19 registry that Stanford participated in, and it really showed a staggering difference in those who were hospitalized for COVID-19 by race and ethnicity. And again, those of you who are clinicians saw this first line. But what this graphic shows is that compared to the local census that normally serve these populations by these hospitals, individuals that were hospitalized for COVID were much more likely to be Black or Hispanic or Asian. And again, these individuals tended to be much, much younger than other groups. So think about not only mortality, but also the cost on families when young people are dying from these kind of diseases. And early in the pandemic, over 50% of the deaths occurred among Black and Hispanic individuals that, again, were younger than white counterparts. We looked at this at Stanford. So in our Stanford data, we found that Hispanic individuals in our area were 3 times more likely than non-Hispanic individuals to have a positive test for COVID during the study. And on average, they were younger. They were 10 years younger. They were more likely to receive a COVID diagnosis in the emergency department. Get higher rates of Medicaid coverage. So that might explain some of that difference. But of course, we know that there's nothing specific about being Black or Hispanic or Asian that makes you develop COVID. This is all a result of the structural factors, so the structural barriers that resulted in an inability to isolate, to be part of the essential workforce. This study shows that, again, excess mortality during COVID was directly linked to people's employments, right? Where do you work? How are you able to isolate, protect yourself? And for some people, not working is not an option, right? And we know that these populations were overrepresented in the essential workforce and did not have the luxury of working from home. And even hopefully as we move towards the aftermath of COVID-19, particularly for cardiovascular disease, we can see the collateral effects of this. There has been an increase in heart disease deaths during the pandemic, again, most pronounced for Black, Hispanic, and Asian adults relative to white adults. And a lot of this is because of delayed care for preventable conditions. Black and Hispanic populations have a higher burden of cardiovascular risk factors. And again, this is due to structural inequities and systems inequities. And now these inequities have been exacerbated during the pandemic. So in summary, we think about structural determinants of health as the umbrella that then affect the social determinants of health. But of course, we didn't talk about lived personal experiences, which are really important to consider. And these are things that we all encounter in our daily practice: implicit bias, discrimination, perception, stigma, and then how those impact cardiovascular disease, health, and outcomes. So now for the last part of the talk, I want to move forward to promote some potential solutions. And there are everyday things that we can do as researchers and clinicians to promote health equity in our research and practice. I'm going to talk about 3 examples of things that we can do. The first is clinical research diversity. 2 is digital inclusion, which is really important as we think about designing our clinical studies or clinical care. And then talk about some practical tips for scholarship. So this topic of diversity, particularly in clinical trials, has garnered a lot of attention recently because there's some regulatory mandates around this, and I think that's really important. And the short answer to this, and I get asked this all the time, what percent Hispanic, what percent Black, what percent Asian? And it's a very easy answer. You just say, we need our patients to match those that have the disease. So if a group is disproportionately affected by a certain disease, like cardiometabolic diseases, they should be disproportionately overrepresented in the clinical trials. And that's just not what we've seen. We've seen this around sex, gender minorities and sexual minorities as well are underrepresented in studies. And that's something that Stanford is really a leader in trying to promote with the PRIDE study and others. Again, age, we tend to underrepresent older adults, and therefore we lack data on our clinical practice on what the best thing to do. Comorbidities, and again, it really is critical and as simple as those who have the disease need to be studied in the trial. This is an example from work led by Ashish Suraju, who was in our group, looking at underreporting of race and underrepresentation in cholesterol clinical trials that affect our practice guidelines. And Ashish found that among the high quality randomized controlled studies that were cited in the guideline, many of those studies did not even report race ethnicity. They just left it out. And very few, you can see that compared to the US Census, there was marked underrepresentation of who was in the study for Black and Hispanic individuals as compared to those, again, who are more likely to have disease. So what can we do? I recommend for everybody interested in this topic to read. You can download this for free. It's a consensus statement from the National Academies in 2022. And it gives you very practical, how to do it. How do you increase the enrollment of women in clinical trials? How do you improve enrollment of diverse population? And again, gives you specific things, for example, the flexibility, inclusive criteria. So you want to try to keep your studies as broad as possible in the inclusion criteria, because you want the results of your study to apply to the broadest population possible. When you look at the recruitment of diverse populations, staff is critical. You want people to feel comfortable with the study staff. You want the sites to be where people live. It's really, really important to go to the community. Language appropriate cultural literacy, sensitivity, work with trusted community partners, and again, diversify the investigators, the team of investigators. One thing that Stanford has really been a leader in, and especially with SCCR, is thinking about how we decentralize clinical trials through digital technology. When we think about the way we used to do clinical trials, a fully centralized trial, and I've been a site PI for this, and I can tell you these are very challenging for many communities, where you have to have the patient or the participant come into your study site, you take all their measurements, and that's just really cumbersome for some people. Even just parking at Stanford is challenging. During COVID, we were forced to move to a fully decentralized protocols, and I think we've learned some good lessons on how we can do this. And I think that now in the aftermath of COVID, we're going to have some hybrid approaches and learning best practices. A lot of things can be done in the community and may actually save money for the clinical trial costs. I just wanted to call out a few examples of where we're doing this at Stanford. We were fortunate to receive 2 strategic focused research networks award from the American Heart Association in collaboration with Morehouse School of Medicine. And this is led by our Chief of Cardiology, Dr. Eldred Lewis. It's called the Diverse Network. And they are currently testing different strategies of how to increase enrollment of diverse participants in ongoing clinical trials. So if you have clinical trials that are ongoing and you'd like to test some of these strategies or participate with the group, I think Kira Clark, who's I think is on this call, can maybe be of help to get you guys enrolled. But it's a really exciting, again, to test the practices. And my hypothesis here is that different strategies will work for different populations. There's not a one size fits all, and studies will have to be adaptive and work differently for different populations. We have also been awarded a training center. And again, at cardiology, we're awesome at making good acronyms. So this stands for Training Researchers to Advance Inclusion Networks. And here we're developing a large group of investigators and training them in the principles of team science, justice, equity, and inclusion around clinical trial diversity. And we'll have open source curriculum that we're happy to share with this group and others who are interested in this. It's also important, as we talk about the social determinants of health, is that all the different social determinants of health that we've talked about are intimately linked with digital literacy and access, especially as we think about study design. So things like your skills, your connectivity, the type of devices you have, you want to try to be as low tech as possible. But again, actually, many people have smartphones, especially in underserved communities, they're actually still very common. And again, training and tech support is critical. There's been a lot of work written around telemedicine as potentially exacerbating health disparities, because some of our most vulnerable populations are exactly the ones that may not be able to easily participate in telehealth. And we see this as an example from UPenn, where they had a lower access to patients who were from historically marginalized groups. This is data from Stanford. So this is work that's led by Neil Kalwani, who's one of our faculty members. And he's doing a lot of work trying to understand the barriers to digital health access in our Stanford communities. And here we see in our CCMG practice that patients with limited English proficiency were much less likely to use video visits as compared to phone visits. And again, we can imagine why that is. And that's because they may require you to have an interpreter in these visits. And that just is an additional technical step. But that is all surmountable. And this is, again, a study by Kaiser that showed that medical assistant supported virtual rooming was associated with successful video visits. It just takes a little bit of extra time and effort. But again, all our healthcare systems need to invest in this. And Stanford actually does this. If you have a visit coming up with a patient of limited English proficiency, they'll send you a message and they'll say, did you set up an interpreter? And the more we can automate this and just be the fabric of the healthcare system, the better we can do with access. This is an example of work done by our group showing that there's the readability of online patient education materials is just far too high. It exceeds the recommended reading level of which is 6th grade by the American Medical Association. And these are just 2 topics that come up a lot in preventive cardiology, things like coronary artery calcium and lipoprotein A. And if you look at patient-centered material that's supposed to be targeted for patients, the reading level far exceeds this recommendation, The reading level, for example, for lipoprotein A articles online is 12. So very, very high, requires a lot of education. And a recent Pew research survey found that 70% of individuals make medical decisions based on health information they find online. So if we're providing health information online that is not readable, it can exacerbate health disparities. And then it may, inadvertently create people going to easier to read websites, which may be misinformation. So what are the best practices for clinical research groups? You want to develop questions and methodological strategies that are informed by conceptual frameworks. And this is really important. You want to have a health equity lens at the study inception. So a lot of times I'll have my colleagues ask me, hey, I'm about to write this study up. Can you just make sure it's good in terms of health equity? And that's just far too late. You need to have the communities involved in the design phase of this study. And we have a lot of support systems at Stanford to be able to do this. The Office of Community Engagement is a wonderful resource and can really be helpful. You want to have form diverse and inclusive study teams and cite their scholarship. And this is not just something that you do for optics, but this results in better science. And there's a lot of data that shows that having diverse study teams leads to more creative ideas, leads to better questions. And whenever possible, especially when you're designing case report forms, you want to collect very granular data on patient race, ethnicity, and social determinants of health. And we know that certain groups, large groups that we have in the Bay Area, like Hispanic and Asian populations, are monolith, and that there's a lot of differences just by major subgroups. You want to try to collect that as best as possible. For scholarship, what are best practices? And there's a lot written on this, so I put the citation there and we'll share these slides. You want to explicitly describe the rationale for inclusion of racial ethnic populations in your methods. And again, I see this error a lot. You want to avoid causal inferences in race and ethnic associations. So it is not that Black individuals are more likely to have COVID or are more predisposed to COVID. It's that there's structural reasons that they have the exposure. So just be a little mindful about language does matter. And you want to contextualize the discussion of the results among these models and avoid the generalized genetic explanations for racial and ethnic disparities. And again, I saw this a lot during COVID, like, are Black individuals more likely to have receptors that make them predisposed to COVID? When the easier explanation is that there are social factors that increase their risk of exposure. And for some reason, that was something that came up later. And there's a lot of documents that give you guidance and updated terminology and definitions. And here are a few. And again, I really like this paper by Dr. Khadija Breath on the groundwork of racial and ethnic disparities in research. There's updated guidance by JAMA, and all the major journals have put out these positions. So wherever you're publishing, there usually is some guidance around this. Then the New England Journal of Medicine now will require for randomized controlled trials that you specify the population, again, that has the disease, and that you've taken the steps to try to include a diverse population that's representative in the supplementary data. So now going back to our case of Mrs. L. So as we think about her and all of her medical comorbidities and all her frequent hospitalizations, are we considering the structural barriers to achieving optimal cardiovascular health? And for her, actually, she also had some strengths. She had incredible family support, and they came with her to all her medical appointments, and she always, did better than expected. So we created a color system around her medications, and you can try to say, these are the ones you can't miss, these are you can sometimes miss, just to try to make things easier. But when we think about designing our clinical studies, we want to make sure that patients like her, that their voices are heard and they're representative. We don't want to do studies that are only apply to a select few. We want them to help the populations that we care for in clinical practice. And I'll end with this. So even the best intentions can sometimes go wrong. So this is a pill box that I gave to my mom, who has many cardiovascular problems. And I saw that she has some random pills just sitting there on the counter. I was like, but how about your pill box? So she's like, oh, I just put those out because I was going to take them later. So again, this business of health equity and trying to get our patients to adhere to medications is an iterative process. There's a lot of humility, and we have to listen to our patients. We have to listen to the multiple stakeholders and keep working at it. So in the take-home points, I hope you learned today that most cardiovascular disease disparities can be explained by social determinants of health. But structural racism is the underlying cause of these disparities. Our science must explicitly and intentionally address structural inequities, and this is at the inception of the study design. And interventions must move upstream of our healthcare system where we all work. I'd like to just acknowledge my wonderful research team, the Health Equity Advancement, the Research and Technology Lab, the Heart Lab, again, good acronym, cardiology. This is our Stanford Preventive Cardiology section. So this is a wonderful group of physicians, nurse practitioners, dietitians, who really work, genetic counselors, work really closely to try to improve the health of our patients through prevention. I'd like to acknowledge our funding sources and leave you with this schematic, which I think we're really trying to work towards liberation. Thank you so much. And now I think we have plenty of time for Q&A.
Thank you so much, Dr. Rodriguez. Really appreciate it. We have some comments in the chat. If I don't know if you want to read it out loud or you want to read it out loud. And then, of course, we will open up to the questions.
Sure. Let's see here. Oh, nice. Donna worked at Brigham. That's good to know. Let's see. How should I think? As people, yeah, we'd love to take live questions, but I'll start reading some from the chat.
Maybe
yeah, so
Lisa
Gohill, I hope I'm pronouncing that correct. And if you're on video, I want to ask it yourself, that's great. But she asks, how should I think about the epigenetic changes for family history that happen over time due to systemic racism? That's exactly right. So there are biological consequences because of racism. So there are actual pathways, and that review article I'm happy to send you kind of goes over the mechanisms for that. But there are true biological consequences from racism. So it's not race itself, but it's the exposure to systemic racism is those factors that can in turn cause differential outcomes in people.
Can I just ask a follow-up question, if I may, on that?
Sure.
Lisa. So then in clinical practice, when you're looking at a patient of a certain race and you know that those biological differences are present, do you treat them in the same way? Or is it a matter of how you frame it for the patient, but you would still, use that data to, to design the intervention differently?
Yeah, I think that's a great question. And even if you want to go broader, again, that goes back to why use race at all. But I think that we don't have a perfect way to capture all this stress and all these biological adversities and lived experiences of individuals. So I think that race still is extremely helpful as we think about clinical factors and clinical risk, not biology, but those risks. So when you design the intervention, and again, depending on what the intervention is, you do consider that. But I don't know if that answers your question. And it depends if it's like, and there is something about ancestry, and my colleague Sho Clark does some work on that. That's really interesting as well. So ancestry can explain some differences. But again, usually when you actually look at a group, for example, like Hispanic individuals, there is much more heterogeneity within that group than between that group. So it's not helpful. So in terms of if you're trying to say like biologically, this Black individual is going to get treated with X and Y, that's different. I will say that there are sometimes because of ancestry some biological differences. So example, we know that for Asian patients in my work as a cardiologist, East Asian patients may be less likely to tolerate higher doses of statins because of a difference in an enzyme that metabolizes the cholesterol medication. So we actually may start at a lower dose. But I think a lot of these differences may be overblown and then they get generalized to other groups and we end up with undertreatment. But there can be some subtle biological differences depending on the question. Again, not based on race, but perhaps ancestry.
Thank you very much. That's super helpful.
And I think that, let me see. I think that may be the only question I see, but let's see here.
Yes,
Jonathan.
there are more comments, exactly. But yeah, please go ahead if you want to read it.
Yeah, so Jonathan David asks, in understanding the prevalence, what are the current ongoing social determinants of health study involving structural racism locally? Oh, this is such a great question. And I'll give a quick plug for a research network that I'm part of called the HEAL Network. and this is run through Bonnie Maldonado's office, that we are trying to get, we know there's so much great work being done around health equity, health disparities in the research space. And we're trying to put them all together. So I can certainly connect you with our network. And we're actually gonna, we give presentations. We're gonna talk about creating funding and opportunities to collaborate. Does anybody want to ask a live question? I see another question from, are there social indexes by zip code available? Yes, Liza Lai asked that. There are, and there's actually some openly available data set that captures social vulnerability index. But again, I would say that some of these are imperfect, because if you said, even where we live, it's such an, there's still disparities within this highly affluent areas, but we do use that in clinical studies and research studies around social vulnerability index. And the more granular you can get, the better. And I see from Liz Ramos is asking, how do you see the role of social workers and mental health clinicians in helping implementing strategies around social determinants of health, or when designing research? I mean, this is critical, Liz. This is such an important question. And for that patient that I talked about, the most important person in that patient's life was not me. It was a social worker. We had a clinic social worker, right? So like, if you have things like food insecurity, if you just can't worry about, like, are you taking the high intensity statin as your LDL goal, things that I worry about as a cardiologist. So I think that absolutely the care team is critical, but especially social workers and people who think about this as you know, their profession. Our social workers are really amazing in the healthcare system. And to your point that yes, we should absolutely work with people who have experience in this, like social workers in our research studies. And again, another plug for the Office of Community Engagement that is able to help us link with community resources around this space.
There's
And
another
then,
question.
yeah.
Oh yeah, please go ahead. Agatha is asking, how do you feel about BMI as measure of health? Have you seen any disparities in usefulness by group?
Great question. And again, like all measures, it's imperfect, but it's kind of what we have and is standardized. It's particularly problematic, we know, for some Asian populations, because BMI is not a reflection of adiposity, of where you have fat deposits. So we know that even a BMI of 25 may be too high for some people, and it's considered normal. So I think we have different cutoffs for different populations. It's useful, again, as a proxy, as a starting point, and again, for consistency across studies. Of course, the more granular we can get, central adiposity, visceral fat, waist circumference, all those things are much more helpful. And yes, but there are significant disparities if we take it as a whole, that we know that certain groups are more likely to be obese by these BMI cutoffs. And I think that is helpful and is a marker of health disparities. I think Donna brings up a great point related to this. Standardized measures were made in a non-diverse population. I think that's such a key point. So remember, our references are based on whoever participated in those studies. And these are not the people that we may see in clinical practice. So this actually came up for echocardiographic parameters. There's a large epidemiological study called the SOUL study, called the Study of Latinos. And they're getting, baseline data on echocardiographic measurements. And it turns out they're actually very different from what we have as normal. So we have two options. We could either say everybody has disease, or we can say, hey, maybe the standards that we used are not appropriate or not representative. The same is true for genetic studies, right? We know that almost all the GWAS genetic studies, 97% are coming from European ancestry populations. So until we have representative populations, we can't say that those standards apply. So that's excellent point, Donna. And hi.
Haley is asking, do you have any recommendations on how to reduce the impact of health disparities and ambulatory care in outpatient population?
I have a lot of recommendations, but I think I'm probably not allowed to say this by the Stanford Healthcare. I think, obviously access is critical. And, there are some issues with access at Stanford. I know some of my patients are able to see me as a cardiologist, but can't see primary care here. So, sometimes working with our community partners is critical. And again, having those lines of communication. I think how we compensate people is also really important, to try to get everyone to work with diverse populations. And again, that sometimes becomes a little tricky with the way that healthcare is financed here. But ambulatory, I mean, but if you're trying to do cost saving, obviously keeping people out of the hospital is the key. So ambulatory, outpatient care, home care is critical.
So there's no more questions in the chat. So please, everyone, feel free to unmute yourself if you have any questions.
Yeah, I have a lot of my friends here, so I'm gonna have to call on people. Yes.
Yes, definitely. This was one of our most popular topics and presentation, and really appreciate your time.
So Sue, thank you. Sue has a question. Hi, Sue.
Hi, Fatima. It's so nice to see your lovely face and hear your lovely voice. So I just wondered what we can do in the community as far as volunteering, helping. We do a lot as far as like the hunger needs and those kinds of needs. But even if you're not a medically trained individual, what are the community needs that we could look at as far as health disparities?
Such an important question, Sue. There's a lot of opportunities, and I think the Office of Community Engagement is one starting point. But for example, the Stanford undergrads have a free clinic that for you, because you have every skill, Sue. You have clinical skills, you have research skills. So I think that's an opportunity if you want to participate in direct clinical care. But I think even almost better than direct clinical care is going upstream. Like, what are the community factors that are causing barriers? So even doing like an information session is so helpful, and battling misinformation. We talked about that patients really rely on whatever source that's easier to comprehend for their care. And I did a lot of these for Spanish media around COVID. And again, all the misinformation that was happening around that with vaccines. So again, whatever you think you can help in and make a difference, because it's pretty amazing how a trusted community member, Sue, with your background, can really impact our patients and our study participants. And then I will say, again, if you have participants for studies that you're running, that sometimes participants from historically marginalized groups or vulnerable populations need a little extra help and again, you saw that picture at the end with equity versus equality. So they may need more resources to make the appointments to participate in the study, to gather the data. And I think that we have to do that. That's not just the right thing to do, but that's part of the research work that we do. So I see, thank you, Sue, for that question. I see a question from Teresa Cotter, who I work for on J7, who's the best. So she asks, how can nurses at the bedside promote equity awareness? So Teresa and I have spoken about this, and it's pretty remarkable how we all have biases, and having open lines of communication. And I think I could share that there was that some of our patients maybe were getting different tests done based on race, ethnicity for the same diagnosis. And again, just bringing those to the forefront and having that open discussion. And again, people may just be doing unwittingly, but we have to call people out and do upstander behaviors, right? So how, for this patient, why are you doing something different that we don't do? And maybe we're missing something and there's a reason, but we want to make sure we check biases at the door. Again, I think the most dangerous thing that happens to patients when they leave the hospital, and I tell my care team, is the medications. People just get sent all sorts of medications. Sometimes patients may not know what they are. They may take double medications. So really spending time for med reconciliation in language that is appropriate and concordant language. Sometimes, again, family is very helpful to have family members and caretakers participate in those conversations. So I think recognizing those things. And then again, I tell this to my clinical team all the time, don't take shortcuts, because those shortcuts will actually cause more work. And the shortcuts that happen all the time in clinical medicine are things like not using an interpreter to speak to a patient who doesn't speak English. Imagine how scary. You're in the hospital, they're doing all these things to you, sending all these tests to you, and people are coming to you and saying, hey, you got chest pain, you're good, high five. That's pretty scary. So I think, again, don't take shortcuts. Do the right thing, and it actually may save you time, because you may order less tests. You may understand something you didn't know before. And again, treat all your patients like if they were a family member, and usually you'll do the right thing. And again, come from cultural humility. Don't make assumptions about any patients based on what you think is their culture or their ethnicity. Any other questions?
I have a question. It's a pleasure to meet you, Fatima. So From experience, when I was a kid, I used to go with my aunt to take my grandparents because they would schedule their appointments together. And my aunt was the main translator. And sometimes I would sit with the other grandparents because they were both having appointments at the same time. So I would try to translate. But then as a kid, it was hard to translate because the doctor would use medical terms. As a kid, I don't understand, but I'm doing my best to translate that to my grandfather. And then as growing older, I took care of my father, and I started to understand a little bit more, and Google was available. So I was able to Google some of these words. But then also now that my father's gone, I'm taking full care of my mom. So I will advocate for her as well. And so when we get reports or when I go into the clinic, I will sit there and wonder why my mom would be like, okay, yes, okay. And she would take it. But my mom didn't realize, like, you have a serious condition, mom, this is not right. And so I would go and sit in and I would ask these doctors if they could kind of explain it to her. I could explain it the best that I could, but if they can explain it in layman's terms to where she could understand, like, excuse me, ma'am, but this is really serious. You have to go to surgery. You have a tumor. But my mom was just thinking, oh, it's just a polyp. It's nothing big. The doctor says nothing big. But when I read the reports, I told her, no, it's serious. We need to go back. And it took me to advocate for her for a whole year to finally have the doctor realize we need to order special tests for her because these symptoms continue to happen. And same with my brother with his condition. Like, I had to advocate for him because he didn't understand the severity of his illness. So how can we, I know doctors, they work with a lot of patients, and I know they study a lot with these medical terms, and sometimes they forget that sometimes people from low income or people that speak English is not their first language, that they don't really understand what you're saying when you use these medical terms. If there's another way that they can explain it to folks that don't really understand, maybe use simple words so that they can understand, oh, wow, this is really serious. I may have a heart attack versus another term that the doctor would use or something like that.
Ruth, thank you so much for sharing your stories. And I'm sorry you went through that. That's illegal. So I'm sorry that happened, and using children as interpreters is illegal. And even like, I'll even tell this to, I'm fluent in Spanish, but I would never, try to speak Portuguese, maybe like, oh, it's similar enough. And I'll bring an interpreter, even though like, it's just the right thing to do, because interpreters are trained they should be, again, to translate things in a way that the patient understands, not use excessive medical terminology. So not just translation, but interpretation. And yes, we all need to do better, not making assumptions and not speaking at a very high level. And again, meeting patients where they are. And this is when you can bring in another person, like a patient advocate, right? And somebody asked, like, what can we do at the healthcare system? I mean, we should have, and we used to have this when I worked in Boston, like an advocate. Like, if a patient has extra social needs, they should have somebody with them to help them, right? And it's pretty amazing. One of my outpatients actually had that, and she had a young guy who just came and helped her, like, download, My Health, and he was like logging in for her, and it was just so helpful and so efficient. But you shouldn't be put in that situation. But it's great, again, the patient advocates, and we saw this happen during COVID when family advocates could not be there, right, because of COVID. How horrible and how vulnerable some of our patients are. So your family is lucky to have you, and I'm sorry you've been put in those positions, and we all can learn from that to try to meet people where they are and not make any assumptions. And even sometimes we may have patients that are doctors, right? And we make assumptions, but we shouldn't do that. We should, again, I'll say, I know you're, I'm not, you're a physician, but I'm going to explain, and again, break it down very simply to everybody. And for us who are now attending physicians or leading teams, if you're in nursing leadership and leadership, wherever you are, it's really important to model this, because again, we're training the next generation to treat all our patients with respect and dignity and humility. I think it's really important. And I'm glad Ruth, where do you work? I'm glad you're here.
I work for SCCR for Project Baseline.
Oh, great. I'm part of Project Baseline. I haven't met you yet. Nice to good to see you. So that's it.
Just to give Ruth a plug, Fatima, she helps people get the tech literacy. That is her role. She's fabulous at it.
Wonderful. Well, that's so great to. So you're putting into practice what I suggested. So thank you. Thank you for being such a role model.
There is one more comment or maybe question. When it comes to systemic and structural racism, when you speak about social determinants, what are things that medical insurance companies could be doing? From experience,
I don't want to get fired. I don't know if I could answer that. Yeah, I think that, again, for cardiology, there are things that work and work well, and I think that insurance companies should let the physicians do what's best for their patient and not make them jump through all the hoops, right? And again, if the rationale is cost saving, so this is like a whole other discussion of health policy, but if your goal is to cost save, letting people get the care that they need when they need it and preventing expensive hospitalizations is cost saving. So we basically need insurance companies that think a little bit longer term as opposed to short term. So that's the short answer. I can talk to you about it offline, Carlos. Any other questions or concerns? Well, it's such a pleasure. Again, to see all my friends on here. And, we have a really great community at Stanford committed to this in many different angles. And I look forward to working with many of you and tackling this important, but hopefully not too daunting problem. And again, I hope that we have a few very practical things that we can do in our day-to-day practice as clinicians and researchers. Thank you.
Thank you. Really, we appreciate your time, taking the time from the busy schedule you have to present to our audience. I really appreciate it. And thank you so much, everyone joining today. As I mentioned, we will send out an evaluation, and especially for those of you who are looking to collect continuing education units or BRN credits, please make sure you complete the evaluation and mention your name in the evaluation, because if you don't complete the evaluation and we don't have your name, we won't know that you are collecting credits. So I will send out the evaluation, and I will include a PDF copy of the slides, and the recording will be available on our website within a couple of days. And I will include the link to our website in my email as well. So we can give the rest of your time back to you if you don't have any other questions.
It's always good to finish early. Okay, thanks everybody.
Thank you so much. Have a lovely rest of the day. I will stop recording. Thank you.
And Susan, I'll send you the slide.